Today's video is about the treatment guidelines and prevention and prophylaxis for the patients of acute rheumatic fever. If there is a person who is exposed to group A streptococcus, then he may acquire the group A streptococcus infection. So first, see here the risk factors like the overcrowding, poverty, and rural residents that ultimately increases the susceptibility of those persons exposed to group A streptococcus to acquire the streptococcus infection. So how we can prevent this? We can introduce some interventions like we can raise the economic development, we can provide better living conditions. Then from group A streptococcus infection, that is the upper respiratory tract infection that progresses to acute rheumatic fever. The risk factors are like asymptomatic infection, or if there is inadequate diagnosis and treatment, and if there is any failure to seek health care for sore throat, this may lead to the acute rheumatic fever. We can avoid these risk factors by having better diagnostic systems, better diagnosis and treatment of sore throat. Now, the patients who had developed acute rheumatic fever, in these patients, females are more susceptible for the Sydenham's chorea. So we should improve access to the health care. Then from the acute rheumatic fever, if the treatment is incomplete, then it may lead to the recurrent episodes of acute rheumatic fever. Then it may ultimately lead to rheumatic heart disease. The major intervention that we can do here is to provide secondary prophylaxis. Again, from the rheumatic heart disease, it may lead to the heart failure and other diseases like the stroke syndrome and endocarditis that may leads to some disability and death. So here we can do interventions like we can provide better management for the heart failure, like providing heart failure medications and other treatment. So this is just an overview of what interventions we can do. So let's come to the treatment part. Now, all patients with acute rheumatic fever should receive antibiotics that should be sufficient to treat the precipitation of group A streptococcus. So for the antibiotics, the drug of choice is penicillin, that can be given in the following forms. First is the phenoxymethyl penicillin. The dose is 500 mg oral twice daily in case of adults, but in children having body weight of less than or equal to 27 kg, the dose is 250 mg oral twice daily. Second is the amoxicillin. The dose is 50 mg per kg of body weight daily, administered with a maximum of 1 gram for 10 days. And the third one is benzathine penicillin G. It is administered intramuscular single dose of 1.2 million units for adults, and for children having body weight less than or equal to 27 kg, it is administered as 6 lakh units. And those patients who are allergic to the penicillin group of drugs, they can be provided erythromycin estolate with a dose of 20 to 40 mg per kg of body weight per day, up to a maximum of 1 gram per day orally for 10 days. Now for the treatment of arthritis and arthralgia and fever, once the diagnosis is confirmed, the drug of choice is aspirin. So initially the aspirin should be administered at a dose of 50 to 60 mg per kg of body weight per day, up to a maximum of 80 to 100 mg per kg of body weight per day in children. But in case of adults, the dose is 4 to 8 gram per day, and it should be administered in 4 to 5 divided doses, and the dose may be continued up to 2 weeks. Now, when the acute symptoms are subsided, then the dose should be tapered, and it should be reduced to 50 to 60 milligram per kg of body weight per day, and may be continued for further 2 to 4 weeks. A special care should be given in the patients taking the aspirin. At higher doses, patients should be monitored for symptoms of salicylate toxicity. The toxicity that the aspirin may cause, these are the anorexia, nausea, vomiting, and tinnitus. These group of salicylates and NSAIDs have no proven value in the treatment of carditis or chorea. Now let's come to the treatment of carditis. First is the management of congestive heart failure. Then in patients with significant cardiac involvement, corticoids, especially glucocorticoids, preferred over salicylates with a dose of 1 milligram per kg of body weight per day, that the initial dose of the glucocorticoid. We are using glucocorticoid because it may reduce the acute inflammation and result in more rapid resolution of the failure. It is usually continued for few days or maximum of 3 weeks. For the treatment of chorea, here the medications do not alter the outcome or duration of chorea. In milder cases, management is by providing calm environment, and in severe cases we can provide carbamazepine or sodium valproate. It is preferred to haloperidol, and the medication should be continued for further 1 to 2 weeks. In resistant cases, intravenous immunoglobulin have been tried, and if it is tried, then it should be limited to the resistant cases, not in the milder cases and severe chorea. Another is a plasmapheresis. Now let's come to the prophylaxis for the patients with acute rheumatic fever. The first category is a patient with rheumatic fever without carditis. For this, the duration of prophylaxis is for 5 years after the last attack or 21 years of age, whichever is longer. Now the second category is a patient presenting with rheumatic fever with carditis but no residual valvular disease. For this category, the prophylaxis duration is for 10 years after the last attack or for 21 years of age, whichever is longer. The third category is a patient presenting with rheumatic fever with persistent valvular disease that is evident clinically or on echocardiography. For this category, the prophylaxis duration is for 10 years after the last attack or 40 years of age, whichever is longer, and sometimes lifelong prophylaxis is also needed. Prevention of the acute rheumatic fever. The first part that we should discuss is the primary prevention. If to say ideally, primary prevention would entail elimination of major risk factors for streptococcal infection, particularly overcrowded housing. But this is difficult to achieve in many places where the acute rheumatic fever is common. So the mainstay of primary prevention for acute rheumatic fever remains the primary prophylaxis. That means the timely and complete treatment of group A streptococcal sore throat with antibiotics. The mainstay of controlling acute rheumatic fever and rheumatic heart disease is secondary prevention. As we know that patients with acute rheumatic fever are at dramatically higher risk than the general population of developing a further episode of acute rheumatic fever after a group A streptococcal infection, so they should receive long-term penicillin prophylaxis so as to prevent the recurrences. The best antibiotic for secondary prophylaxis is benzathine penicillin G, that is administered at dose of 1.2 million units for adults or 6 lakh units if children having less than or equal 27 kg of body weight, and these doses should be continued every 4 weeks but may be delivered every 2 to 3 weeks. Another one is oral penicillin V at a dose of 250 mg twice daily, but actually it is less effective than benzathine penicillin G. Another drug is erythromycin at a dose of 250 mg twice daily. If the patient is allergic to penicillin, then erythromycin can be administered. So that's all about the treatment guidelines, prophylaxis and prevention of acute rheumatic fever. At last I have to say that I am a student of final year MBBS, and I have tried to cover the treatment part of acute rheumatic fever. There may be some mistakes in my teaching, so if you find any mistakes, please do comment in the comment section. Thank you for watching the video.